1.
So now we're going to be talking a little bit more in depth about guarding. We did talk about some of these concepts as we talked through some of the things earlier, but again, now we're going to focus on this in terms of ambulation. So as a patient is walking, so if Abby is walking with me, I'm going to always want to be in a position to be able to help her if anything happens. Again, we have patients that have been in bed for a very long time, so their blood pressure and their other vital signs may be impacted. We also have patients that are on a plethora of medications that can also impact them getting lightheaded, things like that. So I always, even if Abigail is a walkie-talkie, I always want to be in a spot to be able to help her if need be. So again, I want to be in a place where I'm not jamming my hand up into her armpit, again, to protect that brachial plexus, but I also want to be in a position to be able to grab and bring her towards me. Again, my position as a clinician is always in a lunge position and a mini squat, again, to not be impacting my back. As I'm talking to you, I'm twisted, but moving a patient, you never want to have your back twisted. That is the easiest way to get a back injury, is either being too bent over or being twisted as you're moving a patient. So as Abby's walking, if she's a walkie-talkie, I would just be here to help her. Again, even if she's walking fine, I don't want to take my hands off. If I stand way over here and Abby goes down, I can't do anything about that. So again, if she ends up collapsing, I can bring her towards me. If she ends up really collapsing, what I can do is turn my back leg into almost like a human chair. She would then sit here and I would get into a little bit deeper of a squat. I would be able to yell for assistance. If no one was able to bring me a chair in a good amount of time, I could slowly lower Abby to the ground safely. Again, preventing an actual fall. It would be a controlled lower descent of the patient to the floor. So with that too, if she has a walker, it works in a very similar concept. I'm always cueing her not to be too close to the very front of it. We don't want her going forward, and I never want the walker way too far out in front of her, because then again, it can get out in front and she can fall again. Her feet placement is always in the middle of the walker. If she does have an injured leg and is weight bearing is tolerated, like we talked about earlier, then you always go walker, bad leg, good leg. And that's how I would cue her to move. Again, I'm still in the same position. She can walk forward. I'm following her as she's walking. Again, if anything were to happen, I can still pull her into me the same exact way as we just did before. With that too, I'm always cueing her to have her head up so that she's not looking at the ground. We don't want her to trip over anything. And then I always want her hands on these gray grips. Patients have the tendency to either grab on these bars underneath here or try and press down on the grips in front. Again, we showed you earlier that will collapse the walker, which we don't want to do to prevent an injury. So that's kind of how you guard when you're walking a patient.